All right, well, good afternoon. We will get started. Welcome to the first Maternity Action Plan work session of 2024. My name is Brianna Hansen, and I am a program officer with New Jersey Healthcare Quality Institute. Now, before we dive into the agenda, I just wanted to thank you all for being present here today with us, as well as your dedication to improving maternal infant health in New Jersey, and for our out-of-state folks attending across the nation. So thank you very much. During today's session, we will give you a brief overview of our maternity action plan. Then we will transition into hearing from our subject matter experts on food, housing, and security. We're going to transition into our activity, which is our word association. And then we will turn it over to our breakout rooms, which you will all be able to select which breakout room you'd like to join. And then we'll come back together at the end, really to have a group discussion and report back on our thoughts and feedback from the presentations and our breakout room. And then we'll close off our afternoon with some closing remarks from the Quality Institute. And before we jump into the content, I would like to just go over some housekeeping items to ensure that we have a smooth and efficient session for today. So just to let you all know, our session is being recorded today. Really the purpose is so that we can post this on our website as a resource for others to either watch back or catch in case they missed today's session. We ask that you mute your microphone when you're not speaking. This will help us minimize any background noise and really make sure that we're having a focused and productive environment. And as we navigate through today's agenda, feel free to take a step away at any point if you need to. We do not have any scheduled breaks built in, as well as we don't have a designated Q&A portion. So if you have any questions or comments that you would like to ask our subject matter experts, you can feel free to leave those in the chat, or you can save them for our group discussion at the end. Now for our next session here, we'll get right into it. So the New Jersey Healthcare Quality Institute, in partner with many organizations and individuals across New Jersey, created and released the Maternity Action Plan, which is well known as the MAP, in July of 2022. The MAP is a holistic approach to making New Jersey the safest place in the nation to give birth and raise a child. The MAP provides a directional path forward in 4 critical areas. 1, building the maternal workforce needed to achieve birth equity and quality. 2, collecting and using data to improve equity and quality. 3, reforming payment systems to drive high-quality, holistic maternal infant healthcare. And number 4, improving community-based social supports. In 2023, we began putting the MAP into action, hence the title MAP to Action. And similar to today's session, what we did was we hosted virtual work sessions that were focused on each section of the MAP. We invited subject matter experts to discuss how their work improves maternal infant health. Subject matter experts came from various sectors. We had doctors, lawyers, leaders of community-based organizations, and representation from the Office of Medicaid, who is joining us once again today. To view any of the recordings and resources from our 2023 series, please visit our website. You can also use your phone and scan the QR code that you see on this slide, and that'll bring you directly to our MAP resources, and we will make sure to send out the slide to our attendees after this session. We also hosted an in-person convening, which brought together our virtual attendees and focused on networking and connection building. Many of you may remember our Mapping the MAP exercise, where participants identified their area of work and made connections across sectors using stickers and washi tape. This was a great opportunity to match a floating head in a Zoom square to a being in flesh and promote collaboration amongst our attendees. When planning the convening, we really thought about all of the conversations that we had been a part of in the virtual sessions And we were able to mold these into 6 maternal infant health values that you'll see on the right-hand side of your screen. And these were based on the main themes of our attendees, the really themes that we heard consistently and repeatedly brought up. We use these themes as the core to our discussion for our in-person meeting, but also as a central tenet to the work of our MAP continuing. And we hope that these values are in alignment with the focus of the work that you all do as well. So from our last set of work sessions, we also gained more clarity and granularity on the focus and goals of our stakeholders. We refined the MAP recommendations into a one-pager of key themes. The key themes are suggested actions to focus next steps in each of the 4 areas of maternal child health work. Today, our focus is on community-based social supports and services. You'll hear our speakers present on topics that have a direct tie to many of the key themes that you see listed here. More specifically, social service providers and organizations, as well as public and community awareness of programs and resources, as well as linking reimbursement to improved maternal and infant health outcomes, are just some of the topics you will hear us discuss today. The goal of today is to bring awareness to the existing and forthcoming programs and benefits in our state as they relate to food and housing security, as well as providing the opportunity to network and hear from familiar and new faces and voices. We heard from many of you when we reached out most recently that these were areas of significance for you. And as always, we appreciate the feedback and the interest that was expressed in our survey, and we plan to continue to work collaboratively to meet the needs of our audience. Now, I would like to pass it over to Kate to introduce our first speaker for the day and to tee us up for the content portion of today's session.
Thanks so much, Brianna, and I really appreciate you giving that overview. I know we see many familiar faces here today, but many new faces as well, so I think we're well slated to jump into the work. I'm thrilled to introduce our first speaker and first topic of the day. Our topic is how to improve individuals' and families' access to reliable and affordable healthy foods, and we have a wonderful and very dedicated speaker with us today. Melanie Ernest is a dedicated community servant who is passionate about breaking down social barriers and opening pathways for traditionally underserved populations. She's a social worker by discipline and spent her early career working with the New Jersey Department of Children and Families, and has had the privilege of serving as the Director of Human Services in Salem County, New Jersey, before being recruited by the University of Pennsylvania to work as Director of a research project called Behavior Change for Good. Following the conclusion of that research project, Melanie took her current role as the Director of Community-Based Programs at Virtua Health, where she oversees a suite of food is medicine programming called Eat Well. Eat Well consists of a mobile farmers market, food pharmacy, and mobile grocery store bringing affordable foods to the areas of South Jersey where it's most needed. And we're thrilled to have you here with us today, Melanie. I'll turn things over to you.
Thank you so much, Kate. I'm excited to be here today to share a little bit about Eat Well programming with everyone. So we talk about food as medicine now a lot in the healthcare space. It's a pretty new concept, really, for healthcare, but our mothers and grandmothers before us were very, very wise. I'm sure that I'm not the only one who heard the phrase, "You are what you eat." So if you put good things into your body, you get better outcomes. And it's really much more complicated than that, but with regard to getting the nutrition that we need. So if you don't mind advancing the slide. Thank you. We talk about Eat Well at Virtua as a suite of food as medicine programming. We do have 3 different arms of Eat Well programming that 2 are out in the community all the time, Monday through Friday, and one of them is a clinical nutrition program. So advance, please. let's talk about how did we get here? There was a community health needs assessment that was completed in 2016 for the areas of Camden and Burlington counties that identified food security, transportation as two of the main needs in the area. As a healthcare system, we couldn't do much to influence transportation, but we could do something with regard to food security, and that is how our first program, our flagship program, was born. Next slide, please. We looked at the needs of the community. This is Camden County that's shown on the map. The difference in life expectancy is drastic, just within 6.5 miles. And the reason for that is access to resources. Next slide. Oh, let's just keep going until we hit the mobile farmers market. One more, please. Thank you. Our Ewell Mobile Farmers Market brings fresh produce year-round at deeply discounted rates to 10 communities in South Jersey, in the Burlington and Camden County areas. We're out, rain or shine, working with community partners to bring fresh, locally grown as much as possible, fruits and vegetables to the community. One of the biggest benefits to the mobile farmers market program, aside from bringing these fresh and healthy fruits and vegetables out into the community, is that we have a one-to-one match for anyone presenting with SNAP as their form of payment. All of the produce on board is customer choice, so you can walk up, anyone in the community can walk up. There's no pre-registration or requirement you don't have to show proof of income. Anyone in the community is welcome to visit our mobile markets, but you can choose any 6 items for $3, 12 items for $6, or 20 items for $9. But that $9 bag, if you present with your SNAP benefits, costs $4.50. So we're trying to do the most good with getting fresh, wholesome, nutritious foods into the community as much as we possibly can. Next slide. Just a little bit about the impact that we've been able to have. In 2023, we held 474 separate markets, serving nearly 12,000 individuals. Look at these numbers, like almost nearly 105,000 pounds of fresh fruits and vegetables were distributed throughout the counties that we serve. We also have a partnership with Rowan University where we host dietetic student interns, and they provided more than 2,000 nutrition education sessions at the market side. We find that a farmer's market is a really open and welcoming place for people to come and to share recipes and ideas around nutrition and what it means to them, and to learn about the different produce that we have available on board. So having those education sessions at the market side provided a gateway for people to try new produce items that they might not be familiar with. We learned that dino kale was very, very popular because it's pretty and it's versatile, and you can prepare it raw or cooked in a variety of ways. Just one of the many surprising interactions and surprising things that we learned on the market. We also take that time to really engage with the people who come and visit the mobile markets, and we want to make sure that we're doing the most good in the community. So we asked, Are you getting the things that you need from our mobile market? What would you like to see? And we took a little snapshot of the ways that we're working to improve the health of the community. That's on the next slide. So 80% of the visitors who came to the mobile market reported learning how to choose or prepare healthier foods because of the mobile grocery store and the interactions they receive there. I think that's particularly impactful because it's just really looks at the interaction and the relationships that we're able to build in the communities, teaching different ways to prepare and choose healthier foods. 96% of our visitors reported increased fruit and vegetable consumption because they had access to the mobile farmers market. And 91% of our visitors reported preparing more nutritious meals and snacks because of the availability of that produce and the interaction with these dietetic students teaching different preparations. And I can't say enough about the relationship building in the community. Folks come to us now at each of our stops and want to share with us the recipes that they've made, and we do sort of a show and tell with the staff and consumers there. Our next program is our food pharmacy. So if we can advance, please. The food pharmacy looks at a more clinical relationship with food security and how it impacts our overall health. So our food pharmacy program at Virtua is available by referral. Anyone who is a patient of a Virtua primary care or Virtua social worker, or who has a relationship with a community-based health manager can be referred into the food pharmacy program if they have a diet-related health condition and screen positive for food insecurity. Our program is a 6-month one-on-one education program for patients who need help with food security and need help managing diabetes, hypertension, managing weight. Overweight and underweight are qualifiers. We've had some patients who come in with gestational diabetes. We've had patients who see a significant improvement in those conditions over the course of their 6-month education sessions with our food pharmacy. So it is one-on-one, personalized advice on managing your healthcare condition, and patients leave with groceries equivalent to about 10 meals each month when they come in. We also provide resources for additional emergency food supports in the community to all of our patients who present with an immediate need. Next slide, please. The last year, in 2023, we were able to help 2,017 times and 1,201 patients through the food pharmacy. We distributed almost 65,000 pounds of nutritious foods into the community through this program. Next slide, please. I mentioned we're looking at the clinical impacts of food as medicine with our food pharmacy program. We're right now partnered with the American Diabetes Association and the Gretchen Swanson Foundation for Nutrition to conduct a clinical study on the efficacy of produce prescriptions on managing diabetes. So this study launched this month, and one of the benefits of the study is, in addition to the one-on-one education and the supplemental foods, we're also distributing produce prescriptions at every visit for 6 months. So that's an additional $60 that is redeemable in throughout Camden County, but primarily in Camden City. $60 each time they come in. It's redeemable at our 2 mobile markets and 42 corner stores throughout the Camden area. So we're aiming to increase access to fresh fruits and vegetables, not only within the Virtua network, but also throughout the community in partnership with the Food Trust in Philadelphia, who is the originator of the Food Bucks, which is the produce prescription voucher we use for this program. Patients have reported to us that they nearly double their consumption of fruits and vegetables following their 6 months with the food pharmacy. It's eye-opening when you talk to our registered dietitians. We've had, I think the story that struck me the most was there was a patient who came in and said, well, I have fruits in my diet. This morning, for example, I had a jelly donut. So the educational component is just meeting people where they are and building on that month over month during the 6 month time that we have that dedicated space has shown a tremendous improvement. I am seeing a lot of questions in the chat, and I'll be happy to address whatever questions, if we want to email them, or if I think we can maybe answer some of them at the end of this in the breakout rooms.
We're keeping track of all of them for you, Melanie, so you don't have to worry about it.
Thank you. Thank you very much. All right. So, could you advance, please? To the mobile grocery store. One more. There we go. So the latest and greatest program for our Eat Well suite of food as medicine is our mobile grocery store, where we take a converted New Jersey Transit bus out into the community. It's now a one-aisle full-service grocery store where it is it's quite an experience to walk on board, and I'll show you some photos in just a minute. But the focus of the Eat Well mobile grocery store is to go out into communities where there is not ready access to a grocery store. Some rural pockets of Burlington County where there's not a rich public transportation resource, and there aren't grocery stores within several miles. We're also in urban centers like Camden City, where although there are a number of corner stores available, there's not one full service grocery store in the city. Camden is considered one of the top 5 food deserts in the state of New Jersey, and we have 4 regular mobile grocery stops there throughout the week, in addition to 10 others throughout Camden and Burlington counties, and now we're dipping our toes into Atlantic County as well. So if you advance the next couple of slides, you'll see where our mobile grocery store started and where we are today after an extensive retrofit. The bus was donated to Virtua Health by the New Jersey Transit Department, and it took about 1 year to retrofit the bus and outfit it as a grocery store. We have everything on board that visitors might need. When you walk in, set up just like a supermarket. You walk into the produce section, shelf-stable goods and dry goods in the middle, some household goods. Towards the back, we have refrigerators and freezers filled with dairy and proteins. So all of this is offered to the public at prices between 30 and 50% below average retail cost. We're able to do this because of grants and philanthropy. So our philanthropy department is constantly fundraising to keep these programs up and running and out in the community. It's one of the ways that we can influence. I see that. I see Donald's comment, we want that in Salem County. I want in Salem County too. But we are, Virtua is the only healthcare system right now in New Jersey that offers a program like this. We would love to mentor other healthcare systems if they'd like to come, grow a program like this. We would save you all of the growing pains and trials that we faced in building the program. We're in the community Tuesday through Friday with our mobile grocery store. And if you advance to the next slide, there are some statistics on what we've been able to do in 2023. This program was only launched less than 3 years ago. Last year, we held 427 markets, more than 1,100 markets since inception. And you can see with our point of sale transactions, more than 5,000 of our 12,000 total happened last year alone. We get a lot of visitors who use their SNAP benefits to pay on our mobile grocery store, much more than on the mobile farmers market, but it's a different experience for visitors. I think it's because the prices are so deeply discounted on the mobile farmers market that it's easier to use to really stretch those SNAP benefits in other directions. Just this year, over the summer, we added preventative healthcare screenings on board the mobile grocery store. So nearly 1,000 times we were able to offer nutrition advice and a blood pressure screening or a glucose screening right there alongside of the mobile market, so that while our visitors are shopping for their food, they're thinking and keeping their health top of mind. My blood pressure might be high. I need to reduce sodium. How do I do that? Working with the interns from Rowan University and with the healthier choices on board the mobile grocery store. I think I forgot to mention that. About 80% of the goods on board our mobile grocery store are geared to be healthier versions of the items that our visitors would purchase. So we have reduced sodium canned goods, a ton of fresh herbs and fresh fruits and vegetables, and lean proteins. So that while visitors come in, they're not just getting discounted fruits and vegetables, discounted proteins, but they're also getting high quality, nutrient dense, lower sodium, lower sugar offerings. You'll advance to the next slide, please. So we engage with our visitors just to make sure that we are hitting the mark. Our goal is to increase awareness, knowledge, or skills that support healthy dietary patterns. That's why we're in the community. That's why we're a Food is Medicine program. 100% of our visitors have more access to healthy and affordable foods because we're in their neighborhoods. 90% of our visitors learn how to choose or prepare healthier foods because of visiting the mobile grocery store. 96% of visitors report preparing more nutritious meals and snacks. I am encouraged by this and hope to grow this impact and to grow this program in so many ways. And if you'll advance to the next slide, I can talk just a little bit. Well, okay, 2 more. I forgot I put transition slides. Thank you for humoring me. In 2023, one of the many things that we were able to do is we were able to work with the Department of Health and applied for a grant to increase our presence in the community. So one of the things that I'm most proud of is partnering with Virtua across the board and with the community in ways that we weren't able to do without additional supports. You can see my smiling team there and a variety of vehicles in the background. That's because we put together a program called the Mobile Acceleration Program in conjunction with 2 other departments at Virtua Health. So now we have a fleet of mobile healthcare services that address pediatric health, that address cancer screening and preventative care, and food as medicine. So we're out in the community together, really wrapping our arms around the most vulnerable areas where there might not be these resources. We were also very fortunate to be highlighted at the New Jersey State of the Food Summit conference at Rutgers University. And because of this attention and because of the work that we're doing, we were able to order for delivery in first quarter of next year a brand new mobile grocery vehicle where we'll be able to offer enhanced services. I'd like to show you what that will look like. It's on the next slide. Being a mobile grocery store on board a transit bus presented a unique set of challenges. The transit bus is not set up for refrigeration or freezers. There weren't generators or hand washing stations to keep food safe and to keep people safe while on board. So we went through quite an extensive overhaul of the vehicle. And in doing so, we learned a lot of valuable lessons. One is you need to have a backup generator on board all the time because there were instances where the weather was very, very warm or very, very cold when the generator we have currently wouldn't support both the HVAC system and the refrigeration for foods. So it was hospitable for either people or for foods, but not both. Our new unit is a Freightliner RV that is a custom build. So we won't have quite the same issues. We chose an RV because it's made to support running water, it's made to support refrigeration, and it's a more comfortable space for people to be. There will be wider aisles. We will have a dedicated slide out area for private nutrition consultations and screenings, for blood pressure screenings, for glucose screenings. Cholesterol screenings is something that we're adding when we have the new vehicle because these analyzers are very temperature sensitive. And with our current setup, a lot of the preventative healthcare screenings that we did were outside of the mobile grocery store. So if it was a particularly hot day or a very cold day, the analyzers weren't quite accurate. So we're correcting that by having a dedicated space indoors right on board the mobile grocery store where those screenings can happen. And we also will have space to have additional connection to social support. So we have and will continue to cross-promote programs in our service area. And with this private or semi-private space, there'll be a curtain to separate the area from the main grocery area. We'll be able to bring in guests to do SNAP applications, for example, or to do some other work. Okay. Next slide, please. Just want to mention very quickly, we have 2 brand new stops with our mobile grocery store in Atlantic City. Because we are seasoned with offering a mobile market, the Economic Development Association tapped Virtua's mobile grocery store to assist with food security in Atlantic City, at least on a temporary basis. We are in development with some other community partners to pick up that work when we move out of the area. And one more thing, I just want to show you the impact. I mentioned that we collaborate with 2 other programs across Virtua. If you'll advance to the next slide. The Mobile Acceleration Program is a way to combine Eat Well Food as Medicine services with Virtua's pediatric mobile services, which provides everything that a child from the ages of birth through 12 might need. So it's immunizations, lead screenings, hearing screenings, back to school physicals. And they work with families who are uninsured or underinsured. And our mobile health and cancer screening unit, which just launched in August of 2023, provides breast cancer screenings, cervical cancer screenings, colorectal kits, and prostate screenings. And they also work with uninsured and underinsured folks. So wherever there are people who are uninsured or underinsured, there's probably a need for some food assistance as well. And we were able to help really double down on our impact in the community. Eat Well delivered nearly a third more food into the community by partnering with these other programs than we would have been able to do on our own. So that's what I have for you today. Thank you so much for the opportunity to share.
Melanie, thank you so much. I think if we were to all take ourselves off mute right now, you would hear resounding applause. You certainly have quite a fan club after that presentation, and I think a real opportunity to spread this work throughout the state. For those of you who are inputting questions into the chat box, we're not going to address those at this exact moment. When we finish with our next presentation, you'll have the opportunity to self-select into a breakout room, depending on the topic that you'd like to focus on. And so Melanie will be in the first breakout room number 1, and we'll share this list of questions with our facilitator for that group. So there'll be opportunity to dig in, really talk about implementation and getting this good work across the state. We'll also have the opportunity, as I tee up our next presentation, our speaker will be joining us in the second breakout room, and likewise, you'll be able to self-select into that room as well. And we'll be doing a full report out as to the conversations in those rooms. So don't feel like you're missing out since you only get to go to one of the 2. But again, Melanie, thank you so much for sharing this program. And more importantly, thank you for really the tremendous dedication to running this work across the state. So thank you. Next up, we are going to be focusing on planning for and implementation of the New Jersey Medicaid Innovative Food and Housing Related Services as part of the state's federal 1115 waiver program. I'm delighted to introduce John, who will be our next speaker and expert. John Tew is the Policy Director at the Office of Policy and Innovation in the New Jersey Department of Human Services, or DHS, Division of Medical Assistance and Health Services, or DMAS, where he oversees the 1115 comprehensive demonstration, as well as other waivers of federal authority that are needed by New Jersey to run New Jersey Family Care, the state's Medicaid program. He's a lawyer by training, and prior to working at DHS, he worked at the Camden Coalition, and prior to that, the Pennsylvania State Senate. So, John, we're so glad to have you here today. I will turn things over to you.
Thanks so much, Kate. I really appreciate it. Just wanted to note before I get started that also with me today are Shinyi Lin, who leads our maternal health work within the Office of Policy and Innovation, as well as two of our newest members to the maternal health team, Naomi Rosenblum and Lashida Barnes. So just want to let everyone know they're here as well. They'll be in the breakout rooms. So say hi. You can go to the next slide. I am happy to be here and wanted to talk about the 1115 demonstration waiver. It's, as Kate ably did, it's a mouthful. So most people just know it as the waiver, but a lot of the work that New Jersey Medicaid does in housing and food security flow through the 1115. And this is sort of an auspicious time to be talking about it because we just got our next renewal demonstration period approved by CMS. So we're in the heart of implementing a lot of new and exciting things in general, but also specifically on housing and food security. So I wanted to give a quick sort of 101 on the 1115 demonstration waiver, sort of what it is and how we got here. I'll apologize in advance for how dry that section might be, but I think it sets us up nicely for the discussion around the housing support services we're working on. Wanted to briefly touch on our behavioral health integration work, because I think a lot of maternal care and maternal issues touch on behavioral health as well. And then we have a specific bit about nutrition supports and our new medically indicated meals pilot. And then I'll wrap up with just a brief what we've done so far and where we're going with all of these programs. So on the next slide is the beginning of this 101. You can go to the next slide, please. So I always like to sort of put it in perspective that the 1115 demonstration, which you see listed in that middle box, is just one of the levers we have at New Jersey Medicaid to impact policy. The state plan on the left side, that's sort of our basic, it covers everything, but that is the New Jersey family care policy. So the federal government has a series of a menu, honestly, of state plan areas that you can get into and change. And each state looks different, but each state operates within that state plan menu. So the bulk of our benefits and services are done that way. But then in the middle, we have the 1115 demonstration, which allows states to say, we hear you on what we can and can't do on the state plan, but we have some innovative or different things that we want to try out that are state specific or population specific that we really think will work. And the federal government has the 1115 waiver authority in place so that they can give states that go ahead. It comes in 5-year chunks, and you work pretty closely with CMS to negotiate exactly which of the programs and pieces are going to be allowable and not allowable. There are certainly other types of waivers. New Jersey is a state that has sort of brought all of our waiver authority, most of our waiver authority under the 1115. So if it's not in the state plan, you'll probably see it in the 1115. And then just wanted to note on the far right, we have plenty of other policy mechanisms, state law and regs. We have our very long contract with our managed care organizations. There's a lot of guidance that we put out, a quality strategy. All of those things go into the policy of Medicaid. So if I don't talk about it today, it doesn't mean that Medicaid doesn't do it. It just means it's not in that middle bucket of the 1115. So on the next slide, this I think I've pretty much gone over as well. When you hear a lot of people say waiver, often it is shorthand for the 1115 demonstration, but not always. So just be careful to throw around the word waiver because it can mean a lot to policy nerds such as myself. A little bit of history. New Jersey's first 1115 was approved in 2011, so we're on our second renewal, third 5-year period. And it provides the authority for quite a few, as you'll see, major elements in the program. So on the next slide, the current renewal, so as of April 1st, 2023, we started our next, which would be our third 5-year, although I think it works out to a little closer to 5.5-year demonstration renewal period. So we have authority for everything I'm going to talk about through June 30th of 2028. This renewal includes, as I mentioned, the housing services that I'll talk about, the integration of behavioral healthcare services. And then we have a couple of pretty new and exciting pilots that we're doing as well. On the next slide, this is just really something to give a little context to how long it can take to develop and pass these things. You'll see on the top left, we began hosting listening sessions on the renewal approved last April in November of 2020. There's some COVID delays in here, but as you can see moving along here, it takes a while to get all of the state stakeholders together, get with CMS and make sure that they're on board, and finally get passed and approved a demonstration renewal. So it took us from November of 2020 until March of 2023 to get everything together and get it approved. On the next slide, this is something that we at DMOS do for most, if not all, of our big implementations, and the 1115 is no exception. We try to start with North Star principles. What are the things we're going to ground our work in as we go forward through what in this case is a 5-year-long and maybe even beyond implementation? We want to make sure that from the beginning we know when we come to a decision point or when we're scoping out the aspects of a design decision or a program move, we want something to ground ourselves in. And these North Star principles are that grounding. I won't read them to you, but just know that they're here for the 1115. They're grounded in whole person care and making sure that stakeholders and communities are deeply involved in how the programs are designed and stood up. As I'll get to on the next slide, there's a large part of health equity in there. And just want you to know that that is there, and they are a piece of all the decision-making we're doing. So in addition to those North Star principles, or sort of maybe sub part of that, is we're bringing health equity domains, as we're calling them, to all of our work, and the 1115 is no exception. So what you're looking at here is sort of how we at New Jersey Family Care are thinking about health equity as we're implementing all of our programs, but at least for me and for right now, the 1115. And sort of too often, I think people, when they think about health equity, they're thinking about that first circle, the clinical equity. They're thinking about, the pieces of measurable outcomes and disparities that you think about, and that is very important. It's just not the whole story. So we think equally important are the operational, what we're calling operational equity, as well as the agency culture in making sure that the progress you're making in clinical equity is both sustained and replicatable. So briefly, I wanted to go into each domain. The first one, as I said, is the clinical equity. It involves the identification of those clinical disparities and barriers, those drivers of the disparate health outcomes, and then the work to design interventions that will reduce those disparities, as well as measure the outcomes to make sure that we're having an impact. The second domain is operational equity. And this is one that focuses primarily on the member experience of the operational side of our program. So with this one, think call centers, our transportation benefit. This domain goes beyond the clinical disparity to ask what of the operational inequality might be driving a poor member experience. So maybe it doesn't even show up in outcome data, but it's a really important piece of the health equity work. So as an example, we've been very focused on our transportation benefit recently and have made a lot of improvement on the reliability of rides so that members have an accurate on-time pickup, drop-off. If the operational pieces that underpin that transportation benefit aren't working or aren't working well for everyone, then those who don't have independent access to transportation are getting a very different and worse experience of their NJ family care benefits than those that do. So that's a sort of tangible example of where the operational side can really impact clinical, and even if we don't see clinical impacts, can still be impacting members negatively. And then the third domain is working on ourselves on the agency culture. So focusing on making the division more diverse and inclusive, making sure that health equity is a focus across all of our programs and offices and subdivisions. And we want to foster that belonging and shared decision-making within ourselves, both because it's the right thing to do and because it helps strengthen the outcomes and the work in the other two buckets. So in addition to this, I just wanted to highlight the work of Cornell professor Jamila Michener. it's a great place to go for some more and deeper thinking on this. And then just to sort of give you an idea of how we're using this is not just a framework that we sort of use on decision making. There is actively an Excel spreadsheet tracking and collecting issues on each one of these domains, and we have a health equity team that's working on addressing and prioritizing each one. So this is both a framework to think about it and guide our decision making, as well as an active place where we're working on it. So on the next slide, this is where we get into the actual programs that are covered by the 1115. Forgive me if I start picking up the pace here, but I'm gonna try to get to a light overview of everything in 1115 and then drill a little deeper on the things that are specific to housing and food insecurity. This is a list of the major provisions of the 1115, and this is the current renewal that I'm talking about, that supported existing programs. So our managed long-term services and supports, MLTSS, that benefit is through our 1115 and continues with this approval. The community care and supports program through our Division of Developmental Disabilities continues. There's some eligibility changes, expansions that are happening with this, as well as our New Jersey home visiting pilot and some eligibility flexibilities that are changing within the children's system of care, both with our partners at DCF. We continued the 12 months of postpartum continuous coverage, and then our authority to expand behavioral health or integrate behavioral health care into our managed care organizations. That's an existing authority that we're expanding under this one. So then on the next slide, we have the major provisions that are new and that we're, not to say we're not working on the old ones, but these might be the bulk of our implementation work over the next couple of years. That includes, top of the list, our housing strategy. This is Medicaid coverage of housing services, and I'll get into those in a minute as to what exactly they are. This is increased coverage of nutritional services, both through expansions of our MLTSS nutrition services, but also through a medically indicated meals pilot that we're going to be running for individuals at risk of gestational diabetes. We've got a community health worker pilot that's allowing the managed care organizations to propose and test innovative uses of CHWs within NJ Family Care. We have a new incentive program for behavioral health providers to adopt and improve their health, their HIT, their health information technology. We have an autism adjunct services pilot program that's getting up and running, and 12 months of continuous eligibility. Those are all new pieces that we got under this 1115, and we are doing, hopefully you have seen us, if not you will see us doing extensive stakeholdering on each one of these to make sure that all of the community is helping us design and stand these up. So on the next slide, this one's sort of the wah-wah slide. This is some of the stuff that we asked CMS for and was not approved as we proposed it. That includes pre-release behavioral health services for incarcerated individuals. We really wanted to get that up and running. This one is something that we almost certainly will be doing. We got caught up in CMS's timing here. So they were not able to approve ours because they were working on another state's approval. Now that that approval is out, we have guidance. We can come back and make sure that we have a more thoughtful CMS on this topic this time around. So that one's TBD. And then the second bullet is places where CMS didn't say no, they just said, we think you can do this in other ways. So you may have heard of the integrated care for kids model that CMMI is working on. Supportive visitation services, the CCBHCs, and the regional health hubs are all places where CMS thought that it was a good idea, and they just pointed us to different places, to reference back that earlier slide, different places where we could find the authority to implement those. So we'll be working on all of that, just not under the 1115. And then the one place that they were not able to approve was increased federal funding for subacute behavioral health rehab beds. It doesn't change the experience of those beds. It just means that the state budget has to bear it rather than split with the feds. So on the next slide, this is where I'd like to go a little deeper on the housing supports in particular. So one more slide, please. This approval that we got from CMS, and it's under a brand new, what's called health-related social needs, HRSN. It's a brand new framework that CMS has come up with to allow these 1115s across the country to get into the area that I think we've all traditionally thought of as SDOH. You know, housing, nutrition, those sort of outside the bounds of traditional clinical work. CMS recognizes those are really important to the health of our members and to providing good care. So they're starting to get to a place where they can approve federal spending on them. Specific to housing, we got approval to begin our integrated housing strategy for Medicaid beneficiaries. We're going to cover the transition and tenancy sustaining services that would go into providing housing services. We're going to increase MCO accountability, in part by standing up a housing unit within DMOS to make sure that we're taking a look at all of that. And we have authority to do a simple user-friendly assessment process so that we can identify all of our members that are in need. So on the next slide, we got the authority for those large buckets of work, and we started to do a lot of stakeholdering around what each of those were, what each of those will look like. But in addition to the thinking around the design, we owe CMS some further thinking, not just we want to do these housing services, but how are we going to do it? As you can see, what services in particular, what populations in particular, what infrastructure investments are you going to be making to bring this new provider type online in a Medicaid context. So this is just to let you know that we will be further fleshing out that approval and submitting that to CMS for more approval. Next slide, please. So this gets a little more specific into the services that we are doing. We have, as you can see, pre-tenancy, housing transition, and modification and remediation. And there's one more that I'll get to in a moment. But pre-tenancy services, this is the housing search and application process. What can be done to help members with that? The transition services, how do we set up a new housing unit, connections to resources that'll aid with those costs that are not rent, but you know, it's expensive to set up a new housing situation. And then also maybe review the living environment to make sure it meets the clinical needs of the member, which flows into that third column, which is remediations or modifications that might need to take place to support the health of a member, or to support their ability to be in that housing situation. Think AC units, grab bars, handrails, that sort of thing. And then on the next slide, we have our fourth bucket of services, which is the tenancy sustaining services. So pre-tenancy, how do we get up to it? Tenancy transition, how do we get into it? Tenancy sustaining, how do we make sure that you're staying, you're being supported and being able to maintain that housing in the long term? Because that's where you're really going to get the health benefit, is when you can be in that safe, stable housing. So next slide, please. And then this, I briefly saw some questions in the chat about how we can get involved. We would love to have you. So thank you for asking. The housing work groups, we've broken it down into the four groups that you see. They are, I will say, fluid. Originally, these four, which started in the summer and continue on into 2024, they are based around the specific questions we needed to answer for CMS. We're in the process of moving through them and seeing which ones maybe need to have their charter a little tweaked so that we can continue to work on exactly what we need to do to stand it up. So we did a lot of work in the eligibility and services work groups to make sure that the populations and the services were fleshed out and were what members are going to need. I think in 2024, we're going to spend a lot more time with the administrative structure, maybe the infrastructure work group, to make sure that we're ready for what we're hoping is a 2025 start of these housing services. So please get in touch if you would like to be a member of these work groups. These are pretty wide open. Just bear with us as we figure out what the new version of them will be. And they're pretty open. We want to hear from everybody. It's got a lot of housing providers, advocacy groups, managed care organizations, a little bit of everyone who touches us and who will be touching housing. So please come join us. Next slide, please. So really quickly wanted to talk about behavioral health integration, because I think it's important in general, but also as part of the bringing together our maternal work, our housing work, our everyday operations on clinical health work. So the managed care organizations to date, our partners there, are primarily covering, not entirely, but primarily covering clinical health. The bulk of the behavioral health coverage in NJ Family Care has been fee-for-service. We are just beginning the process, and it's going to be a big lift, but we are beginning the process of moving those services into managed care. As you see here, it's going to be a multi-year phase-in. We've started and continue another robust stakeholder process, which again, please get in touch if you want to be a part of. There's a place for clinicians, there's a place for members, there's a place for just about anyone who touches behavioral health. And we'll be reviewing those services and moving them into managed care as we can and as makes sense. And this is going to give NJ Family Care a much more robust view of a member's health. So we don't want clinical health to be separate and distinct from behavioral health. We don't want the housing situation of the member to not be in communication with the other two. Like, we really want the full view of the member's health so that care management and resources can flow to those that need it. So on the next slide, this is just a real quick timeline. You can see we're about halfway through it. We're in that second column right now. Community meetings continue throughout, so please get in touch. But as you can see on the far right, winter 2024, 2025, about a year from now, we're hoping that phase 1 implementation begins of moving those that first batch of services into managed care. So next slide. This is the opportunities to engage. As I said, we have member focus groups. We have a large stakeholder work group that's more informational. We have provider forums. There's an advisory hub. I won't belabor this, but get in touch. We would love to have you. The next slide. So here's where we get into the food side a little deeper. And as I said before, MLTSS is going through, well, let me back up and actually speak to the slide that is in front of you. We've got a bunch of these major demonstration initiatives that are coming online. I've talked about them all before, but the bottom two are the ones that I want to highlight here, which is in MLTSS, we are really expanding the nutritional services that are offered to members. And then separately, so not just MLTSS, we're going to be running a medically indicated meals pilot. And that's going to be a small number, maybe 300 members a year, but that's going to be testing out what meals specifically tailored to the needs of the member, someone who is at risk of gestational diabetes, can be, how can that impact the member, and then how could that maybe be scaled into a larger program. So we're just getting that one up and running, but is a place of intense design focus right now. And on the next slide, just wanted to real quick name check the nutritional supports. These again are specific to MLTSS, so not broadly available to NJ Family Care, but we're talking about nutritional counseling, grocery provision on a short-term basis if there's an emergency that impacts a member's ability to get their own groceries, and then one-time pantry stocking when there's maybe a transition from a nursing facility to the community. So these are really important nutrition benefits that are coming online in the MLTSS program. On the next slide, this is where as I wrap up here, just wanted to give you a quick status update on a couple of the places we've been working. So housing, I mostly gave this already, but our stakeholder outreach has really focused on making sure that we understand housing, because we don't, we're Medicaid. So part of what we're really hoping to do as we move into these housing services is to supplement and backstop, or whatever we can do to improve the housing services that already exist. We don't want to come in and disturb what's already working or get in the way of a housing ecosystem that has been going for years without us and will go without us in the future. Like, we just want to improve, not get in the way. So our next steps on housing, we have a lot of they're called protocols or deliverables due to CMS that will outline a lot of the eligibility and service definitions, as well as working on the infrastructure investments that I outlined before. Behavioral health integration, same thing, continuing with the stakeholder process. We have a lot of updates to our MCO contract that'll need to be done. We started those and more to come. And then, as you can see in the next steps, we're starting provider-focused work groups to make sure that those providers delivering the services will be integrating get a chance to speak to us directly about it. So on the next slide, these are 3 other areas that I just wanted to highlight because they've got a lot going on. I mentioned the behavioral health IT investments. That's called the Behavioral Health Promoting Interoperability Program, or BHPIP. That one is it builds out of an SUD PIP program that we've already worked on, but providers are eligible to get incentive payments based on upgrading their health IT. We're almost ready to launch that July 1st, so stay tuned on that. Community health worker pilot that I mentioned earlier, the managed care organizations proposals are due the end of February, so we're about to get started on evaluating those with CMS and hopefully getting them up and running soon. And then the real boring stuff is on the right, but that's the stuff that actually makes the rest of it work. We owe monitoring reports to CMS every month. We're working on an evaluation plan that will evaluate all of the programs that I've spoken to you today. And that's an important part of making sure that we're not just doing this for doing its sake. We're doing it, we know it works or it doesn't, and we can scale from there. So we have a bunch of deliverables there around the quality improvement strategy and the monitoring and evaluation plans that we're working hard on. So with that, I believe that's my last slide, although if we go to the next one to make sure. Yes, thank you. All right, I appreciate everybody listening, and I'm looking forward to the breakout session.
John, thank you so much. Again, if we were all off of mute, I'm sure you would hear our applause, but you can certainly just imagine. And once again, there were a number of questions that came through in the chat, and so I've been taking those down. We are going to take a short get your brain and blood moving exercise with Brianna, and then I'll be introducing the breakout rooms. So I'll turn things over to Brianna, and then I'll see you all in a few minutes.
Hi, everyone. Thanks so much, Kate, for passing that over to me. And definitely appreciated all of the content that we've gone over for today. We are going to play a short, quick activity. I promise it's low lift. We are also giving you this opportunity to take a quick bio break if you need, but you have to promise to be back by 1:15 because we will be starting our breakout rooms and want to make sure that you are with us for that portion. But I did just drop a link in the chat. Please click on that and open that up. We are going to be playing a game called Word Association. It takes a few minutes. Really, the goal is to stimulate the group's creativity, and we're going to see how everyone either thinks differently or similarly. So when you open up the link, you are going to see a word at the top of your screen. And we ask you to write the first 3 words or short phrases that come to your mind and press submit. And you can only submit 3 responses. But once you submit, we ask that you come back to the Zoom screen so that you can watch your responses as well as your peers' responses populate onto the screen. Please also do not X out of the tab because we will be using this site for some of our other exercises for today. And if for any reason, you want to include some responses or reactions to the words that we already have populating, please feel free to use the chat. This is awesome to see so far. I see someone put in the chat colorful veggies. That goes very well and on point with our colorful words populating. And I'll give everyone another about 10-15 seconds if you want to include any of your last minute thoughts. I see vitamins on here. Necessity, I love that one. Minerals. security, safe fulfillment. Wonderful. All right, so now we are going to do another word. If you just give us a moment to set that up. All right, and if you can go right back into that link, similar, if not the same instructions, go ahead and write 3 words or phrases that come to mind when you hear the word home. Love. I see our word security has come back up. Belonging. Comfort. Thank you, Nima. Peace. Essential. Stability. Haven. Happy. I love that one. Now, I want to give the opportunity before we go into the breakout rooms to see if anyone would like to come off mute and share a thought or any emotions that you had while going through this exercise, or even some responses to some of the words that you saw on the screen.
Brianna, if I may, home also may signify a place where trauma occurs.
Yes, thank you so much for bringing that up. That is a very valid point for many individuals. Home isn't always a safe or secure place for many. So it's important that in the work that we do, we're ensuring that we provide that safe space or safe shelter for our clients and individuals. So thank you so much for raising that point. I'm going to turn it back over to Kate to give us some information about our breakout rooms. Over to you.
Thanks, Brianna, and thank you all. I hope you have had a chance to shake it off a little bit. I noticed that there are very few people who have their cameras on, so I would invite you as we move into breakout rooms to just pop your camera on if you're able, because otherwise we will be imagining what you look like behind your black box, and that could be both fun or dangerous. So we, like I alluded to, we will have 2 breakout rooms today. The first will be focused on food, particularly related to Melanie's presentation, and you'll see it labeled as such. And the second will focus on the housing and food security programs that are part of the 1115 waiver. And more broadly, if there are questions or conversation around the other components of the 1115 waiver that were brought up, happy to discuss those as well. This is a chance for those questions to be answered that were put into the chat box. And we've also given the opportunity to our facilitators and speakers, both John and Melanie, and John, I believe, is bringing along some folks from Medicaid, the opportunity to ask you all questions and engage you in conversation. So there really will be opportunity for collaboration. We'll be coming back together after these breakout rooms for a report back. So don't feel like you are having too much of FOMO for only getting into one of the 2 breakouts, and certainly we'll be sharing all of the notes. So you will see a box has popped up on your screen inviting you to join a breakout room. Please feel free to enter one of those rooms right now. If you're having difficulty entering one, we will have Quality Institute staff who are here in the main room who can assist you, but please feel free to join theme 1 or theme 2 now. Well, welcome back, everyone. And thanks for sticking with us. We appreciate I think all of the robust conversation that was happening in the breakout rooms, and I'm certain this echoes across both of them, but we probably could have stayed there much longer continuing in discussion. So we hope that this serves as one of many opportunities for us in the future to continue these conversations. We are going to do a report out, and so our first of all, we will be continuing to use the Mentimeter site that Brianna just dropped in the chat as a way for us to capture all of your comments and thoughts as we are doing our report out. For those of you who've been with us in the past, we've used Jamboard as a tool. Unfortunately, that is no longer a website or online platform, so we're switching over to Mentimeter. Feel free to drop your notes or thoughts there as we're going. We're going to have a report out from group 1 first, and then we'll turn it over to group 2. And as time permits, we'll have opportunity for a little bit more discussion in this larger group. So whomever is the reporter for group 1, which was the food breakout room, you are welcome to take yourself off mute and we will highlight you.
Good afternoon, everyone. My name is Karen Barnett, and I'm the reporter for the wonderful work that is already being done in Virtua with their mobile farm market and their mobile groceries initiative. We talked a lot about the logistics and the finances of how that program was set up. And we were informed that a lot of that was done through in-house philanthropy. One of the things that they did was when their mobile farm market is 6 years old and new to the healthcare component, and their mobile groceries is 3 years old. What they did was they kind of utilized resource maps, the Food Bank of South Jersey, which has a lot of data, and community health needs assessments to look at where the gaps were in individuals accessing food and actually reducing food insecurity. As far as the financing, it took about $250,000 to get up and running. And one of the major challenges were finding vendors that would work with the smaller amount of product that they were needing. And they actually partnered with Whole Foods and some other vendors, but Whole Foods being the major vendor because they were able to find in and out of season products by partnering with them. They talked about sustainability of the initiative, and one of the things that they're able to do is use community benefit dollars to actually be able to sustain that. So that I think that was key, in addition to identifying those vendors for those of us that may be in less affluent areas when we're looking at getting hospital systems and or organizations to attempt to duplicate that. I think that is very, very key, because we're not talking apples and apples. We're talking various fruits when we look at the bandwidth for communities to be able to implement this and also sustain that. They're able to actually accept SNAP payments because they have the one central, they're able to use Virtua as their central place where they're able to register for those payments. And to break it down a little bit further, one of the things that they have to deal with is almost like a non-compete clause. So there's a circumference, a radius that they're able to service where it does not impact other vendors. So I think that for those of us who are, especially Salem County, since there are no vendors in Salem County, really, I think, Don Noblet, I saw your comment. This would be a phenomenal undertaking for Inspira Health Network and for South Jersey Family Medical Care because of the disparities that are in place in Salem County. One of the other things they talked about was that they use a newsletter to actually stay in touch with individuals that use that. They really don't take down a lot of real data as far as the users. However, they do have a community health worker that is on board, and that is the individual that Melanie indicated does a lot of the direct contact and builds rapport with those that are using those systems. We actually talked about the fact that they only carry 25 items on within the mobile groceries, and if that's incorrect, somebody please correct me. However, the cost of those things are so low that people really can get a lot of bang for their buck. So I think it's a phenomenal initiative. I would encourage individuals to see how they can partner, especially since we are in New Jersey and it is the Garden State, to see how, even if we cannot provide a full complement of fresh vegetables and fruits in and out of season, that we're able to actually maximize on those things that are in season and make sure that we're getting those healthier alternatives and options to our community members who need them so desperately. And if I missed anything, please, anyone that was within our group, jump on and give support. Thank you.
Thank you so much, Karen, for that great summary, very comprehensive. And I also appreciate your signs in the background reminding us of all the good things that we should be doing, like breathing. I do have two quick questions for Melanie that have come up, and I think this is just a good time to ask them before we transition to the breakout from the other group. And as you can see, the screen shared behind you are the notes and comments that have come up that people are putting into Mentimeter. So if you've got other comments or thoughts, please feel free to drop them there. We'll also be passing those questions on and can share the answers via email in follow-up. Melanie, could you quickly share how your food programs are working with community-based organizations that serve pregnant people as clients, and whether you work with any prenatal providers?
Certainly. So we do work with the Perinatal Cooperative in Camden County. We hold pop-up markets there, as they're not part of our regular roster of stops, but we do reserve Fridays and Saturdays for community events and markets outside of our regular roster. So we do partner in that way. Wherever there's a need, we aim for service to 50 or more individuals to create a pop-up market with our mobile farmers market.
Great. Thank you so much. And thank you for Group 1's report out. I will turn things over to Barbara from Group 2 to give the report out on the 1115 housing waiver room.
Hello, everybody. Karen, I cannot compete. You were amazing. I'm going to do my best. Okay, so first, I just wanted to say thank you for allowing me to be part of this. This is new to me, so I'm really excited about being here. Just give me 1 minute to get my notes together here because I'm having some technical problems. Can you all hear me all right?
Yep.
Okay. All right. So I'm having trouble with my screen, so give me 2 seconds and I will.
Barbara, breathe.
Okay.
I'm cheering you on.
Thank you.
You're most welcome.
Okay. So a lot of the questions were answered from the chat, but most importantly, Jonathan was gracious enough to share his email address with us. So he is more than willing to work with anyone and everyone in the group that is interested in being a part of the solutions that we're trying to create with regards to the 1115 waiver. Obviously, the more information we provide to him, the more he can go and kind of fight for us and fight for the things that we need for our clients and for the services that we're looking for. I have some specific questions that were answered that are actually in the chat. I don't know if I have time to read all the answers, but they are there, and there are also is his email address, which he has graciously provided to all of us, and anyone interested in any area of the process in obtaining better services, additional services, or enhancing the ones that are already in place. He is encourages all of us to just send him the email with what you're looking for to do, and he'll let us know if we're able to do it, and why we can't, if that's the reason we can't, and things to that sort. So I really can't read the whole thing easily, so I don't know if there's anything more that you needed me to add, Kate.
Nope, that's great, Barbara. We had John answer a lot of questions, very technical questions about the 1115 waiver, and we will be sharing out all those responses, particularly related to how it's similar or different than other housing programs going on in the state, and how it interacts potentially with assistance for paying for rent, and what's being done in a couple of other states. So we'll share that out. But echoing what Barbara said, John was very kind as to share his email. Certainly, we will hope to overwhelm his inbox with all of the support of those of you who want to volunteer for these stakeholder groups. We have really not enough time for a lot of conversation, but Karen, I see that you raised your hand, so I'll jump in and let you come off mute for a moment.
Thank you. And this was specific to, I'm seeing a lot of individuals within the Cumberland County area who are not living in rent-controlled units. And now that all of the supplemental dollars for COVID have gone away, their rent is being increased sometimes in excess of $300 per month because they're not in a rent-controlled unit. And we're having a lot of those individuals who are they're teetering on being homeless. How will this program assist them? And how are we balancing the fact that there isn't a large pool of affordable and or income controlled units within the state of New Jersey? And then my other question was in reference to how are community health workers being utilized in the community health worker pilot?
So I'll go in reverse order. Is that okay, Kate? I saw you come off.
Yeah, absolutely. Yep,
Okay.
jump in.
So I'll try to be quick. The CHW pilot is going to be up to 5 different proposals from the managed care organizations themselves. So we don't know what they look like yet because we haven't gotten the proposals. We're hoping to sort of get the best thinking from around the managed care organizations and get hopefully 5 pretty different and innovative programs up and running. So stay tuned on that as soon as we get the updates, or maybe ping Raquel, because I think she might have a better idea than we do yet. On the housing, I will say it is going to be an issue that we need to tackle. Medicaid is not the answer necessarily. So a lot of the housing services that we're standing up are helping people find resources, helping people find housing, helping people navigate the process. Because we're not on the paying for rent side, it's going to be a lot of partnership, I think, for our services to interact with other existing services, or maybe, gaps that probably exist. That's going to be a delicate dance to figure out how to address what you're talking about, because I don't know, without the ability to pay rent, how much Medicaid services can plug that specific gap, so much as wrap around existing or new services that can help navigate.
Thank you, John. Thank you, Melanie. Thank you all for participating today. I know that there's still more questions and more hands up. So I think what that really shows us is that we hit on a critical topic to all of you, which is really what we're trying to do. We know that we can't cover everything in 2 hours, and that's why this is a building dialogue and partnership with all of you. You certainly know where to find us, and in this slide, which we will also send out, here's where you can find our resources. And we want to continue to engage with you and share your resources with the other people that are part of the MAP work with us. So a couple items. First of all, I just wanted to alert to all of you who are interested. We have a session tomorrow that is focused in particular on midwifery practice, and the QR code for that session, which is tomorrow from 1 to 2, is on the screen. We will be talking about the importance of midwifery integration into clinical settings and team-based care between midwives and physicians. So please review those resources, and we hope to see many of you at that session tomorrow. I also wanted to remind you to save the date, which is September 20th, for our in-person all-day MAP session, and to look for our upcoming MAP sessions. Our next session is in April 24th specifically, and it will be focused on using real data to track our progress on maternal infant health quality measures and improvements. So race, ethnicity, and language data to be specific. Again, I want to thank our speakers. I want to thank you for your partnership. Right after this, we have a survey, which we hope you'll take. It's just a couple questions for us to constantly improve. And also, we always have that questionnaire for you to fill out and share with Brianna about what your organizations are doing and how you would like to connect with us and others and ways that we can support you in your work. So please fill that out. It helps us help you. And we look forward to seeing you at one or more of these engagement events. Thank you all and have a wonderful day. Take care.